Posa will now begin.
Good afternoon and welcome to today's webinar. It's Surviving Sepsis, Early Recognition and Management of Sepsis, presented by Lake Superior Quality Innovation Network. Lake Superior Quinn is comprised of three organizations: EMPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides will be available on our Lake Superior Quinn YouTube page within the very next week. And as a reminder, you can also post questions in the chat box. Now I'd like to introduce you to our speaker today, Pat Posa. She is the Population Health Clinical Integration Leader for St. Joseph Mercy Health System in southeastern Michigan. And in this role, she's implemented a risk prediction tool and associated interventions within the hospital and post-acute settings. She also works as a Quality Excellence Leader for St. Joe's Mercy Hospital in leading initiatives to reduce hospital-acquired conditions, readmissions, and other quality-related areas. Pat has been involved in many qualitative and patient safety programs such as hospital and system-wide sepsis management program and a statewide Keystone ICU patient safety initiative. She has been faculty for multiple state and national clinical collaborative, including the Surviving Sepsis Campaign Phase 4 Collaborative. And now I'd like to turn this over to Pat. Welcome, Pat, and thank you so much for providing your excellent expertise today.
Thank you, Gloria, and welcome everyone from the great states of Michigan, Illinois, and
Wisconsin, and Minnesota.
All right, awesome. So we're going to talk today about recognizing sepsis in the post-acute setting. And so our objectives today are to talk about why sepsis, why now, and why in the post-acute setting. We're going to talk a little bit about the journey of sepsis in the acute setting, and I'm going to share the story of our sepsis journey at St. Joe's in Ann Arbor, Michigan. And then we're going to talk about a collaborative approach to improving sepsis care in the post-acute settings, focusing on the skilled nursing facilities. We'll talk about early identification and management of sepsis, and then also a focus on infection prevention. Hopefully that's what you came to hear today. One of the things that's important as you embark on this sepsis journey is to really ensure that everyone understands why sepsis, why now. There are many faces of sepsis, and you can see three faces here. This is from the sepsis.org website, which is from the Sepsis Alliance, which is a nonprofit organization trying to impact the general knowledge of increasing public awareness of sepsis. And they have a great YouTube video called The Faces of Sepsis. I would encourage you guys to listen to it. Based on the technology here, we couldn't play it for you, but again, it brings it home to why are we doing this. These are real people. You can see here on the screen, it's young and old. It's not just the elderly, but you'll see that there's a significant portion of this population, of the older population, gets sepsis. And I have my own faces of sepsis. I have two sepsis survivors. My mother-in-law, who is now 88, she just turned 89, and she's had sepsis 2 times in the last 3 years, and has survived because of interventions and standardized processes we've placed in the hospital. And most recently, my husband ended up with, he has a history of valve disease and he's had a valve replacement, and he ended up with bacterial endocarditis and over the Christmas holidays. And because of the processes that had been put in place, he was recognized early and given the appropriate interventions, and he is doing great. And so is my mother-in-law. So I'm sure that this touches all of us, and I'm sure that you have someone in your lives that's been touched by sepsis, and I'm sure in your healthcare organization you have many patients that have been touched by sepsis. So as you begin this work, putting a face to that sepsis experience is important to encourage and help engage the frontline staff for this important work. We know sepsis is the major cause of morbidity and mortality worldwide, 10th leading cause of death overall, 750,000 new sepsis cases in the U.S. annually. And it's the most expensive condition treated in the hospital. But what keeps me going and what has led my focus on sepsis for the majority of my 37 years in practice is that more than 500 patients die each day just in the United States from sepsis. That's like 2 planes crashing, no survivors every day. Wow. If the general public knew that was happening, I think there would be either mass hysteria or major concern. It's beginning to come into the public's awareness. We've had some celebrities that have called out that they've died, or their family members have called out that they've died of sepsis. Most recently, Patty Duke, the Pope died of sepsis, and so I think we're beginning to see it called out more, and that's good, because we're not going to impact its overall mortality until it has the same face in the community as someone with a heart attack or with a stroke, and people are generally aware and can get them, the patient, to a healthcare facility in a timely fashion. The CDC has become very involved with an extension from infection prevention to focusing on sepsis. So you can find lots of good information at the website that's up at the top of the screen. We know that 80% of the sepsis begins outside the hospital, and that's why that public awareness is so important. 7 out of 10 patients with sepsis have recently used healthcare services or have a chronic disease requiring frequent care. We know that the 4 major areas where the infections are that lead to sepsis include the lungs, the urinary tract, a gut, and skin. As healthcare providers, we need to think sepsis and act fast. And all of the healthcare providers, as well as all of our patients and their family members, need to know the signs and symptoms of sepsis. And you can see the nice picture up at the top, which is a great educational tool. Sepsis hospitalization increases significantly with age, and so you can see here that in all ages that the rate of hospitalization per 10,000 population sits around 24 to 25%, and it's divided male and female. But as you get increasing age over 65, and then you exponentially increase when you get over 85. As I have an example, my mother-in-law 2 times in 3 years. So it's the 85 and older that have the significant hospitalization from it, and often suffer the most dire consequences. The common causes of hospitalization in general, I showed you that sepsis hospitalization increases significantly when a person is over the age of 85. But if you look at just common reasons for hospitalization in patients over the age of 85 are pneumonia, urinary tract, and septicemia. So falling into those categories. This is one hospital's experience, but it plays out nationally. They looked at what percentage of their admissions had a sepsis diagnosis, or of their acute care discharges, and 11% had a sepsis diagnosis. But then they looked at what was the diagnosis of their deaths in the hospital, and 48% had a sepsis diagnosis. So only 11% of the admissions or discharges are sepsis, but almost half of the deaths. And so that was at one hospital, but there was a study produced by Kaiser Permanente in Northern California, and they looked at their hospital as well as national and found the same information, that 1 out of 2 to 3 deaths in hospitals are related to sepsis, and most of this sepsis is present on admission. They also found in Kaiser Permanente that as they looked at patients meeting the criteria to get the evidence-based interventions that are called out in early goal-directed therapy, that comprised about 32.6% of the sepsis deaths. But patients that had a normal blood pressure and lactate were comprised close to 56% of the sepsis deaths. So when patients come in to our facilities, they might present with just an infection. If they present needing all of our evidence-based interventions in the ER, they have a more likelihood of surviving. If they don't progress till later, those are the patients that end up dying. So sepsis also has a significant associated readmission rate, and that readmission rate is up to 30% at 90 days, but sits around 20% at 30 days. And sepsis now is the most costly, higher proportion of readmissions than heart failure and acute MI, and the most costly. Often our sepsis patients, because they are older, their disposition after discharge from the hospital isn't to home. So you can see here that 36% go somewhere else, and they go to a long-term care facility or a subacute. I'm sorry this slide is a little fuzzy, but what it's really calling out is that in Michigan, all-cause readmission to any hospital septicemia is the highest reason. And so the sepsis readmission rate is 21% to any hospital, 16% to the hospital that discharged. So we've taken over heart failure and COPD and the other common reasons for readmission. So what has your hospital done to decrease sepsis mortality? And I know that we have a variety of people attending the call today. We have some hospital providers as well as skilled nursing facilities, subacute providers. And what I'm going to talk about now is our journey at the hospital and why it was important for us to reach out to the post-acute arena and work with them on early identification of sepsis. So we began our journey back in 2005, soon after the Surviving Sepsis campaign published guidelines out in 2004. And we knew we needed to standardize our sepsis care, and so we developed a sepsis program including early identification and screening, and we implemented that in March of 2006 in our ED and ICUs, and then expanded that early identification to the floors in 2007, and then house-wide. And we're part of Trinity Health, and Trinity Health started a collaborative in 2010, and we've been a part of that for a while, since 2010. As we continue to look at the evidence and as we wanted to get better outcomes, we did some protocolizing of some early interventions. We began a code sepsis. We worked with our ambulance companies and did screening pre-hospital so we would recognize the patient early. And then we began doing some education in our extended care facilities, and in 2016 worked with them to put in screening processes. So that's kind of been our journey. And so the key components of any hospital sepsis program should be at the foundation infection prevention, and then screening for early recognition, every patient, every shift, developing nursing protocols to ensure early intervention for patients with severe sepsis. We defined placement criteria, we standardized our ED and ICU care, and then we began to expand it beyond the walls. And so we've EMS screens for sepsis. I shared with you and we'll go into detail on the skilled nursing facility screening program. And then we're also beginning to screen for sepsis in home care, focusing first on our oncology patients. So what can the post-hospital providers do? Well, so the first steps we did, we knew as the Affordable Care Act was in place and just the right thing to do is we needed to work closely with the facilities we were sending our patients and trusting the care of our patients to. And so our organization developed a collaborative relationship with all of the facilities that we send patients to, and it's called an Extended Care Collaborative. As we began the work on sepsis, we identified our top 10 facilities that we sent patients to, and identified that we sent a lot of sepsis and we had readmissions from sepsis. And then we sent out a call to participate, explaining the program, the commitment of the facility, and the importance of engaging the leadership. And so we defined what the program was, what the expectations of the facility were, and we'll go into detail of that. And then we had the administrators sign off on it because it was important to have the whole facility's buy-in to participate. So, the program was a 6-month program, and right now we're doing it over 12 months, and we're meeting every other month. But you can do this and meet every month. So you can do it either way. In 2016, we met every month for 6 months, and in 2017, we're doing every other month. So we have a face-to-face meeting, and we followed our local extended care collaborative meetings, so we already have the facilities there. And we walk them through action plans to implement an early identification and management program for sepsis. And we also focus on infection prevention. Now, as part of the program I did in 2016, and we're doing it in 2017, on that opposite month, we do site-specific coaching calls. And they're only 15 minutes long, and it's really just a check-in to see if they understood what was discussed at the prior meeting, and we set aside homework that they have to come and present on at the next meeting. And so we want to make sure there aren't any questions. And so, in fact, I have 3 calls this afternoon. And then we also provide training and educational material. Our goal is to not have them have to reinvent the wheel. And so we provide them with, in partnership with MPRO, with a lot of good educational materials and then resources out in the community. We've also defined some process and outcome measures so that we can evaluate the success. So we clearly define the roles and responsibilities for each of the facilities. They must identify a team to do this work, and it needs to include at a minimum the medical director, the director of nursing, and their infection prevention nurse. And federal regulations now require each facility to have an infection prevention nurse, so this is a good time to get them involved. Also, they're required to show that they're doing process improvement. And so they are using this collaborative to demonstrate that they are working to improve their processes. The team then works through the action plans provided within the time frames. So they're going to they are expected to implement a screening process and then early management of sepsis and educate their staff on screening and managing sepsis. And we ask them to assess their current state related to infection prevention practices for pneumonia, UTI, and central line associated bloodstream infection. And then we have them identify one intervention in each of those areas based on their current state assessment and gap analysis to improve upon. And we're just at this point having them collect data related to sepsis. So as we educate and begin this collaborative, we do exactly what I did at the beginning of this presentation, educate them on why sepsis, why now, educate them on what sepsis is, definitions, and evidence-based management, and then we review the early identification process through screening. And this work has been proven successful in the inpatient environment, and as part of the Surviving Sepsis Campaign Wards Collaborative, we demonstrated that early recognition through routine screening, not just using computer alerts, is necessary and can significantly reduce time to antibiotics and fluids and prevent patients from progressing into septic shock. So part of that education is helping the staff understand that sepsis sits on a continuum, begins with infection, and then the body has a over-response or a dysregulated host response, and they develop SIRS, or systemic inflammatory response syndrome, and these are the 4 criteria of SIRS. And then if I have 2 or more of those, the temperature, the heart rate, the respiration, or the white blood cell count, and I have an infection, now I have sepsis. And I continue to progress on the continuum if I now develop a new organ dysfunction related to the infection. So I have an infection, I have 2 or more SIRS, and now I have an organ dysfunction. And we go through and we explain what are you going to look for in those organ dysfunctions. And you'll see in our screening tool that we focus on the areas and organ systems that they can easily identify in the skilled nursing facility. And it turns out that those are the organ systems that most often fail first. So cardiovascular, looking for that drop in blood pressure, and that's often a late sign. In our younger patients, it's a fairly early sign in our older patients. And that's a systolic blood pressure less than 90 or a 40 millimeter of mercury drop from their baseline. Respiratory-wise, we're looking for an increase in oxygen requirements. They don't usually do blood gases, so we've tweaked it a little bit to something that they can respond to. Renal-wise, urine output, if it's less than 0.5 milliliters per kilogram per hour, that shows that the kidneys are being compromised, or a creatinine jump up of 0.5 or more. Not all the facilities have the ability to get quick labs, and so basing it on other signs and symptoms is helpful. Metabolically, it's that unexplained metabolic lactic acidosis, and facilities usually have to send out the lactic acid, so we have them send it out, but we have them look for other signs of organ dysfunction, not just the lactate. So we're using the current definitions of infection, and sepsis is infection plus 2 or more SIRS, and severe sepsis is infection plus 2 or more SIRS plus a new organ dysfunction. And then septic shock is someone that has severe sepsis that has a lactate greater than or equal to 4, or they have continued hypotension after a 30 milliliter per kilogram fluid bolus. Now we know that the Society of Critical Care Medicine and the European Society put forth new sepsis definitions in February of 2016, but they have not been prospectively validated, and so we are currently still working with the old definitions. So we know, and we've known since 1904, that except on a few occasions the patient appears to die from the body's response to the infection rather than from the infection. And that is a key concept to understand, and it's really about catching that patient early in the process and aggressively treating them so that they don't have a significant dysregulated response. So there's an imbalance in homeostasis. Too much coagulation occurs, too much inflammation, and not enough fibrinolysis. And so here's a schematic, and we review this when we educate the staff at the facility, the nursing staff at the facility, they need to understand this pathophysiology so that they understand the disease course. And it's been well received. And so we know that the target organ for this dysregulated response is the endothelial membrane. The bugs come in, and the body launches a response to the bugs, the neutrophils and the monocytes. The neutrophils cause the release of a bunch of inflammatory cytokines that cause vasodilatation and increase capillary permeability and rev up that inflammatory response. Together, the neutrophils and the monocytes cause the release of tissue factor that starts the coagulation cascade, yet we're not bleeding, so now we make a lot of microemboli. And at the same time, the breakdown of the fibrinolysis is suppressed. And so now we have a lot of microemboli. And so what happens is we cut off our normal circulation. So we don't get enough oxygen to the tissues, and that's where we see end organ dysfunction. So here's a picture of the microcirculation under the tongue in a normal, healthy individual. On the right-hand side, this big dark thing is the venule, and on the left-hand side are the arterioles, and you can see nice capillary loops. The capillary loops are right here. Let's see. Nice capillary loops. Well, it's not letting me draw, but anyways. And so now we're going to look at a picture of someone with septic shock. You don't see those nice capillary loops, and if this was moving, you'd see a lot of little microemboli. And so this is the pathophysiology that's occurring in this population, and that's why they end up having end organ dysfunction. A picture is worth 1,000 words. So how do we manage this population? The management is, first of all, if you don't have an infection, you can't move into sepsis, so working on infection prevention is important, and that's why we do focus on it in the program that we do with our skilled nursing facilities. The other cornerstone is screening and early identification, and then early interventions, identifying the source, controlling it, getting blood cultures, broad-spectrum antibiotics, and then for someone who's hypotensive, beginning resuscitation. And if they move into shock, then it's time to go to the hospital, but our skilled nursing facilities can begin some of those early interventions. The Surviving Sepsis campaign published new guidelines this past February, and in it they call out severe sepsis and septic shock are medical emergencies that need to be treated and resuscitated immediately. We know that in order to get our best outcomes for our patients related to sepsis is by early identification, early antibiotics, and early fluid resuscitation. And so because this is a common disease in the elderly or the Medicare population, CMS has made it a core measure as of October 2015, and so we're expected to put in these evidence-based interventions, and it's called the Step 1, and these interventions, once someone has the signs of severe sepsis, so they have an infection, 2 or more SIRS, and new organ dysfunction, then we need to do these 4 interventions: measure lactate, get blood cultures, get broad-spectrum IV antibiotics, and if they're hypotensive, administer a 30 milliliter per kilogram fluid bolus. And you'll see that these interventions are being done in our skilled nursing facilities. We review some of the key research that tells us how important the antibiotics and the fluids are. Here, this study from Kumar that was published back in 2009 looked at the impact of the initiation of inappropriate antibiotics on patient survival. And what they found was a 5-fold decrease in survival if the initial antibiotics were inappropriate. So it's important to hang the right broad spectrum, and also it's important to hang it quickly. And so this study looks at the duration of hypotension before initiating the appropriate antimicrobial therapy, and each hour of delay decreases their survival by 7.6% per hour. So important to share this information with the staff in the hospital as well as in the post-hospital setting so that they can understand how a simple action of hanging an antibiotic is key to saving this patient's life. Most of this work is based on, and most of the evidence-based interventions are based on the work of a study, early goal-directed therapy, that was done at a single site here in Michigan at Henry Ford, where they brought the identification down to the ER, again, the early, and then they resuscitated quickly to certain endpoints. And what they found was a significant reduction in mortality. And this was the first time that we had seen that. So it's standardizing the approach, recognizing it early, and using common interventions of fluid resuscitation early as well as antibiotics. So once the antibiotics and fluids are given, if the patient is still hypotensive, then we apply vasopressors and we remeasure lactate if it's initially elevated. And if they still are hypotensive or their initial lactate's greater than 4, part of the CMS requirement is that we reassess their volume status and ensure that they have adequate tissue perfusion. And so in the hospital, we do that a number of ways. We can either do it by a reassessment by the clinician or some hemodynamic monitoring. So early identification through screening is key, and that's the intervention we're putting in place in the skilled nursing facilities. And you can see this is an example working with some of our colleagues within Trinity Health in the southeastern Michigan region. This is a tool that they put in place based on a tool that we had in place in our hospital, acute hospital. And so again, it's just looking for infection, looking for SIRS, looking for organ dysfunction, and then probably the most important piece of the tool is if you screen positive, what do you do next? And we'll go into detail. This is the tool that we've partnered with MPRO. Again, it has the same content. The difference in this tool is this can be used for multiple screening episodes, as opposed to the prior tool was one screening episode. And so let's walk through this tool. You start off with screening, and we recommend that you screen upon admission daily, and most of the facilities are screening at least daily for 2 weeks, some up to 3 weeks, and also with a condition change or for the time the patient is on antibiotics if they come to them with a known infection. So the first question you ask is, do they have a known or suspected infection? If the answer is yes, then you move on to section 2. And section 2 is to look for SIRS, and so you're looking for SIRS. Blood glucose in non-diabetics was added back in 2008. If I haven't checked those two, then it's a negative screen for sepsis. If I have, then I have sepsis, infection plus 2 or more SIRS. I should put the patient on I&O so I can record their urine output, get a lactate, and then look for organ dysfunction. And so I'm looking in the main areas, respiratory, cardiovascular, renal, and central nervous system or mentation. And so these are things that the facility can do very easily. The lab should only be used if they're not older than 24 hours. And so if I have any of these organ dysfunctions, now I have severe sepsis. I should check the patient's advance directives and then call the doc. And when I talk to the doc, I'm going to use this script. The patient screened positive for severe sepsis. How did they screen positive? Let them know if they're being treated for an infection because maybe you're dealing with someone who's just covering. Share other key assessment information, and then the recommendation is that this patient needs blood cultures, a CBC, lactic acid, and IV antibiotics. And if the patient's blood pressure is less than 90 or 40 millimeter of mercury less than the baseline, can I have an order to administer 30 milliliters per kilogram of fluid over an hour? And if the blood pressure after that fluid bolus is still resolved, I can call you back, but should we send that patient to the ER? Now, similar to in the hospital, we have challenges with people feeling comfortable putting in a 30 milliliter per kilogram fluid bolus. According to the CMS bundle, you have 3 hours to do that, but we know research tells us the sooner the better. And so that's why it's important to have the medical staff on board and to educate both the medical and nursing staff how important that fluid bolus is. And you can, if you're concerned, you can give it over a few hours, but the recommendation is to give it as fast as possible. So we developed an algorithm. Some people like it in an algorithm format, and this does the same thing as the screening tool we just went by. One of our facilities chose to put it in a different format using different graphics, which is great, making it their own. And when someone screens positive for severe sepsis, they're really putting in this bundle of interventions. So they're getting blood cultures, they're getting a lactate, they're getting IV antibiotics, and then it's encouraged to increase your frequency of monitoring this person, vital signs, INO, and then continue to watch them for condition changes. So we've tried to also link this with current processes that are in facilities. Very much a lot of facilities use a program called Interact, and so the CNAs we are instructed to stop and watch, and if they notice any of these things, to let the nurse know. And so if they've been triggered by the stop and watch and the CNA's telling the nurse that there's been a condition change, then the nurse is going to screen for sepsis because they want to make sure that that condition change isn't related to sepsis. Now, there's lots of resources. Minnesota has done a great job with, and they have a great website that has a lot of tools to be used by skilled nursing facilities, so I'd recommend you going there, and we can send links. I'm not sure if I put them on the last slide. Also, New Jersey has put in place a toolkit for facilities, skilled nursing facilities to use with their hospital association, so those are other good resources as well. So we work this similar to any other process improvement, where we're walking through the phases of performance improvement, and part of that includes getting an action plan together and in completing each of those steps of the action plan. And so here's just a generic early identification of sepsis action plan. Get your team together, develop your screening tool and process, get your medical staff support for screening and early intervention, develop and implement an educational plan for your staff, and develop patient and family educational process and tools, and then evaluate if you are screening correctly and if you are screening. So at each of these meetings, we provide homework for the teams so that, and they come back the next time and have to share their homework. And which is really important to do because it's not going to, as you maybe you remember, maybe you don't, on our journey in sepsis back in 2014, we began going and reaching out to the skilled nursing facilities and doing education, increasing sepsis awareness. But until we had them walk this journey with us and put in a process, it wasn't sticking. You know, education is only as good. You guys won't remember anything but 20% of what I just shared with you by the end of today. And so by having them create a new process and embed that process into their daily work, this becomes becomes lasting. It's sustainable. And so the team, this is an example of after the first meeting, the homework was they had to complete 1 through 3 on the action plan, and then with that screening tool that we gave them, they needed to go back and screen 10 patients so that they could screen patients and get familiar with it. And in fact, after we review this screening tool, I actually put up a case study and we screen together to see if they have any questions, so that they get some practice before they go back. Now they go back and do it in their own environment and come back and share what they learned, what the issues were, and if they had any questions. So here's a typical agenda as we progress through those 6 meetings, so either in every other month or every month. We review the homework from the prior meetings, so we do a round robin where they talk about how they did, and so the second meeting will be how you did in your 1 through 3 on your action plan, and what did you find when you screened those 10 patients. What were issues, barriers, and the group problem solves, and they help each other, and we learn from each other, which is why it's so important to have this face-to-face. Then we typically review, discuss the next area on the action plan, or as we finish sepsis, then we'll move on to the different infection prevention strategies. And then we define the homework for the next time. So here's an example of, this was our second meeting, and you can see it's a round robin. We discussed the implementation of the sepsis bundle, the action plan, and what the homework was, and so they're going to focus on staff education and who's going to provide it and how they're going to provide it, and then we have them sign up for coaching calls. So with data collection, it was important to have them collect process metrics, because outcome metrics take a while to change, and there's also lots of confounding variables into impacting outcomes. And so you're not going to impact an outcome unless you're reliably doing the process. So we really focus on the process metrics. And so we have them look at each week, do an assessment of all of their patients, and you can do it in divided work. So say you have a facility that has 100 beds, and so I might not be able to do 100 beds at the same time. So I do 25, I do one hall or one module each day. And I look to see, of those 25, how many were screened. And so maybe I had 20 screened per our recommendation daily, and sometimes some of the facilities are doing it every shift, and that's based on whether or not they're doing vital signs every shift, and then you can do screening every shift if you are doing vital signs every shift. So are we screening? And then we take a subset of that, and you look at, and we've asked people to look at 10% of your sample size to see if these patients were screened correctly. So now you have to go in the chart and look to see, if I was screening the patient at the time that the nurse screened the patient, would we screen them the same? And that identifies educational issues, and so we encourage them to audit the correct screening on different nurses so that you can ensure that each nurse understands. And then we ask them to do a deeper dive into a patient if they transferred them to the hospital for an infection. Because what you'd want to see is, if I transfer someone to the hospital for infection or sepsis, was that patient screened appropriately? Did we identify the patient in a timely fashion? And then did we do those interventions? And so we can look to see where we still have opportunities for improvement. And then in outcome metrics, we provide data to them on unplanned transfers back to the hospital and mortality. So we have the facilities complete the process metrics and submit to us monthly, and then we're working with MPRO to help us with the outcome metrics. So once we finish the early identification and education on sepsis and they complete that action plan, then we move into infection prevention. And the 3 areas that we focus on, which are the 3 common areas for infection, you saw by the CDC, and then we threw in Class C just because. So pneumonia and UTI are the top 2. So here's an example. So just like we had a action plan for sepsis, we have one for each of the infection prevention areas. So this is the example of the pneumonia. So agree on evidence-based practice to implement. So in the session that we're going to talk about pneumonia prevention, I review all the evidence-based literature on strategies to prevent pneumonia. And then the group is sent away with homework to understand their current practices based on what the evidence says you should be doing, what are you doing. And then they come back with a gap between current practice and what the evidence says. And then they identify, based on the gap, what changes do they want to make, identify barriers to implementing those new practices and strategies to resolve them. And this is where there's lots of interaction, and then they're going to educate the staff on the new practice and implement the new practice. And then we're not going to expect them to turn in their audits to us, but we encourage them, just like with sepsis screening, to audit their process. And so most of the facilities, and I'll just give you an example, for pneumonia prevention, they looked at their oral care practices. And they found that they were not where they thought they were. And some of it was the supplies that they had. And so they re-educated, they got new supplies, they re-educated everyone, the CNAs on the importance of oral care. And one of the anecdotal stories from one of the facilities was they had a dentist come in once a month and do an evaluation, and the dentist, after they had done this change, the dentist said, okay, what did you guys do? All of these mouths of the patients that are here look up. And so that was really satisfying to the group that they were already making a difference. So what learnings did we have? You have to have the support of the facility administration, and the director of nursing or their designee must attend each meeting. We found that coaching calls help to clarify expectations and answer questions. And we try to provide as many tools and materials as possible so that we know that these facilities are often resource thin. And so if they don't have to do any of the background work and create PowerPoints and look up all the evidence, we try and give them all that so that it's easier for them to do it. And we found that it was really important to have the face-to-face meetings to increase the engagement, networking, and sharing. So, that's the end of our story, and I'd like to open it up now for questions, and I want to thank you guys for your time and attention.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your phone. Again, if you have a question at this time, please press the number 1 key on your phone. Our first question will be coming from Anitra Presley with Henry Ford. Please go ahead. Anitra, your line is open. Anitra, your line is open.
Oh, no, I didn't have a question. I'm sorry.
Okay. Our next question will be coming from Barhishra. Please go ahead with your question.
My question is, do you have access to the recordings of this webinar? And hand out the material?
So the educational webinars that we provided, that we worked on with MPRO?
Uh-huh.
Yeah, so we can get you the links to those recordings, right, Gloria?
Yes, we can.
Yes, the recordings are available on our YouTube channel, and the link is in the chat box.
Okay. Thank you.
You're welcome.
While we're waiting for another question, I just want to remind everybody to complete the evaluation.
Our next question will be coming from Kathy Carver with Imperial Healthcare. Please go ahead.
Can download the PowerPoint.
Sorry, we heard half of that question. Say that again.
Is there any way that we can print up the PowerPoint
from today's presentation?
Yes.
If you would like the slides from today's webinar, just email Gloria. That information is in the chat box.
Okay, and then also, you talked about a follow-up sheet to the sepsis protocol sheet. We don't have that. Where can I get it from?
So what follow-up sheet are you talking about?
It's for the actual sepsis protocol. Isn't that a two-part sheet? One for the actual sepsis protocol and then one as a follow-up tool?
So is this what you're talking about that's on the screen right now? So this is the sepsis screen.
Okay.
The screen's at the top, and if they screen positive, then at the bottom is the follow-up that they do with the physician. Is that what you were asking?
Yes, that's what we were asking.
So we can make this tool available as well.
Okay. I thank you very much.
You're welcome.
Our next question will be coming from Rachel with Brookside Care Center. Please go ahead.
Hi, Rachel.
Hi. We're wondering how your hospital readmission rates have been since you put this in place for sepsis.
For sepsis, so we have seen a decrease. It has not reached statistical significance yet, but we have seen a decrease, and we have a large amount of anecdotal information from the facilities that they're finding patients and intervening and not having to send them to the hospital.
Okay, thank you.
Mm-hmm.
Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key on your phone. Again, if you would like to ask a question, please press the number 1 key on your phone. Again, if you would like to ask a question at this time, please press the number 1 key on your phone. Okay, there are no more callers in queue for questions at this time.
Pat, could you also just talk a little bit about some of the challenges or barriers that some of the SNFs may have encountered, as well as how well this program has been received?
Sure. So as I've shared, the challenges in implementing any program, especially related to sepsis, they have similar challenges with giving the fluids, but getting the medical director on board and the nursing staff and showing them the evidence and then sharing their successes with their teams at the facility has helped significantly. Also, some of the challenges are that there's often players that change frequently in the facility. So a DON might be there for a year or might switch out after 6 months, or people rotate positions in the facility. And so we often are helping them play catch up if the transition, all the information didn't get through. So that's been a challenge if you're on the hospital side and working with the facility, and I'm sure you deal with that in the facilities, that you have people come and go, and how do you ensure that this keeps going. And so it's really about having that embedded into your processes. A number of facilities in our area have electronic medical records, and they've put this into the electronic medical record. So it just becomes a normal part of their process. And as a result of that, it doesn't matter if they lose their infection prevention nurse or they get a different director of nursing, it's now become part of their process, and it'll stay.
Could you also, if there are any questions, could you also share with your audience how you are expanding this program to other hospitals and systems?
Yeah, so in the southeastern Michigan area, we have a couple other collaboratives that are hospitals partnering with post-hospital facilities, and so we've shared this model with them, and some of those collaboratives are adopting it. Also, in my parent organization, Trinity Health, I'm doing a train-the-trainer so that they can model this in their states, and Trinity Health has hospitals across the country. So I think we have 6 or 7 different systems across the country that are partnering with, that are going to use this program to, again, help partner with their post-acute facilities to improve out the patients. So it's a labor of love. It's not easy to do, but it's really important, especially as we're in this current healthcare environment with ACOs and clinically integrated networks and cost sharing and BPCI, and we have to work together, and we want to make sure that the patients that start in the hospital and then we send them to a different facility are getting the care that they need, and we want to help the different facilities provide that care. And so it's really sharing the 10 years of knowledge that we've had related to sepsis management and now extending it beyond the hospital. It comes with all of the issues of any change, and so good change management strategies, getting good buy-in, and that's why it's important to get that upfront support from administration as well as from the medical director, and then working together and sharing stories. The facilities have been able to partner with each other, and they, call them up and say, at the meeting you did this, and I forgot how you got that done. Can you help me? And it's because we're not. It's for the patient, so let's not compete on the quality. Let's help everyone have great quality.
Thank you, Pat. We are nearly at the end of the hour. Is there any other questions in the queue?
No, ma'am. There are no callers in the queue.
So there's a question by someone about coming to Wisconsin. So if you want to use my email address on the slides and email me, we can talk offline.
Well, thank you, Pat. And thank you, everyone, for joining us today for Surviving Sepsis, Early Recognition and Management of Sepsis. And as a reminder, these slides will be available on our Lake Superior Quinn YouTube page within the next week. I'd like to thank everybody for attending, and have a great day.
Thank you, ladies and gentlemen, for joining today's call. You all may disconnect.